Welcome to World Med School. My name is Dr. Khalifa Bojang. I'm a consultant pediatrician and senior clinical scientist, MRC Unit, Gambia. In this micro lecture, I'm going to talk about malaria in children, and I will cover burden of disease, clinical features, diagnosis, treatment, and prevention of malaria in children. Globally, there were an estimated 207 million cases of malaria in 2012 and an estimated 627,000 deaths. 90% of all malaria deaths occur in sub-Saharan Africa. Again in 2012, malaria killed an estimated 482,000 children under 5 years of age, 1,300 children every day, or one child almost every minute. In malaria endemic countries, malaria in pregnancy causes 10 to 20% of low birth weight babies, and low birth weight is a risk for increased morbidity and mortality in newborns. In addition, malaria causes reduced school attendance. With reduced school attendance, a school child will not be able to perform as well as his or her peers, which may have a long-term negative consequence for the child and his or her family. Malaria also impairs intellectual development. This applies especially to those children who develop severe malaria, such as cerebral malaria, which we will cover later on. Again, this child will not be able to realize his or her full potential. So what are the clinical features of P. falciparum malaria? Malaria presents with a range of features. After sporozoid inoculation, some children will develop asymptomatic parasitemia, and they may happily live with the parasite without causing any major problems. Asymptomatic parasitemia is believed to be important in developing partial immunity. However, a small proportion of those children will end up developing clinical malaria, and about 1 to 2% of those children will develop severe disease and death. Why some children will only develop asymptomatic parasitemia and others go on to develop severe disease and even death depends on a number of factors, including their immunological background, environmental factors, and genetic factors as well. In addition, if a child presents with malaria, is treated early on in the course of the disease, he or she is unlikely to progress to develop severe malaria. Clinical features of non-severe malaria in children. Malaria commonly presents as non-specific febrile illness, thus making it difficult to diagnose based just on clinical features. As febrile illnesses are common in endemic countries, therefore a high index of suspicion is important in a case of suspected malaria. Other features include abdominal pain, vomiting, and mild diarrhea. Older children may complain of headache and general body pain. Severe malaria is a complex multi-system disorder which affects all age groups, although in endemic countries it tends to affect children and pregnant women. It presents with a range of clinical features which again varies in different age groups, and also the clinical pattern will depend on immune status, age, and degree of malaria endemicity in a particular area. This diagram shows common features of clinical syndrome in Kenyan children with severe malaria. Children with severe malaria in this study presented with malaria with respiratory distress, severe anemia, malaria with impaired consciousness. Some of the children had more than one syndrome, and mortality was highest in children with severe respiratory distress. The numbers in bracket shows the number of cases studied, and the percentages gives the mortality. For example, malaria with anemia without any other complication had the lowest mortality in this study, 1.3%. If a patient presents with all the three syndromes, that is severe anemia, impaired consciousness, and respiratory distress, the mortality was very high. In this group of children, it was 34.7%. Other features of severe malaria include prostration, which is defined as generalized weakness, so that the patient is unable to sit, stand, or work. Generalized multiple convulsion, defined as more than 2 episodes within 24 hours. Deep labored breathing and respiratory distress are other features of severe malaria. Hypoglycemia as well, here defined as a blood sugar level of less than 2.2 millimoles per liter or 40 grams per deciliter. These are the main features of severe malaria. There are other less common ones which tend to occur in adults. So let's discuss in detail some common syndromes of severe malaria. Severe malaria is defined as unrousable coma not attributable to any other cause in a patient with falciparum malaria. It is a heterogeneous syndrome at metabolic derangement, including hypoglycemia or subclinical convulsions, are important in many cases. Sequestration of parasites play a major role in some cases. Respiratory distress. It presents with deep breathing with indrawing of the bony structures in the absence of localized chest signs, and it suggests metabolic acidosis. It has a poor prognosis, and these children must be attended to as soon as possible. And thirdly, severe anemia. There are more than one cause of severe anemia in a child with severe malaria, and the causes include direct destruction of parasitized red blood cells, indirect destruction of non-parasitized red blood cells by immune mechanisms, and marrow suppression associated with imbalance of cytokines. In any one child, there may be more than one mechanism responsible for severe anemia. So what can we do? So the first step is to ensure rapid access to safe and effective treatment in a child with malaria. Secondly, try and prevent malaria infection. Provision of safe and effective treatment. Early diagnosis is important, because if a case of malaria is diagnosed and treated effectively, then that child is unlikely to develop severe disease. In endemic countries, access to treatment becomes important. In some rural areas, treatment may not be easily available. And thirdly, treatment must be effective. An effective treatment will increase the chance of curing a disease. Malaria diagnosis. Thick and thin blood smear microscopy examination remain the gold standard for diagnosis. It has got an advantage in the sense that you can quantify the parasitemia and you can identify the species parasite involved as well. However, it requires supply of electricity and technical knowledge, which is not always available in some settings. Recently, antibody-based rapid diagnostic tests that detects number of antigens, including histidine-rich protein 2, lactate dehydrogenase, or aldolase antigen. These have revolutionized the diagnosis of malaria, and these tests are relatively simple and can be used in areas where there is no electricity supply and lack of skilled staff. It can be taught to field staff who can use this, and increasingly antibody-based rapid diagnostics are being used for diagnosing malaria. One disadvantage of HRV2-based tests is that they may remain positive for weeks after acute treatment. So a child who tests positive could either be they've got an acute infection or the infection has been treated but the test remains positive. Thirdly, polymerase chain reaction again is used in specialized centers for diagnosis. There are other methods as well, but these are the key methods used for diagnosing malaria in children. Treatment must be effective. Chloroquine was the drug that was most widely used for treating malaria. However, because of resistance to chloroquine, it is no longer recommended in many settings. Other drugs that have been used, including sulfadoxine pyrimethamine and mefloquine. Unfortunately, resistance to these two other drugs have also developed and spread to many parts of the country. Because of the concern of increasing resistance, artemisinin-based combination therapy is recommended by WHO for treating both uncomplicated malaria and complicated and severe malaria. Artemisinin have got a number of advantages. They are rapid acting, they have few side effects, and acts on the sexual stage, the gametocytes, which could potentially reduce transmission. Why combination therapy? The reason being, artemisinin monotherapy is not very effective, and combination therapy reduces the likelihood of the emergence and spread of resistant parasites. So as a result now, combination therapy is recommended globally. There are a number of tools available for preventing malaria, and it's based on understanding the life cycle of malaria parasite. The tools include indoor residual spraying, insecticide-treated bed nets, chemoprevention with antimalarials. Indoor residual spraying has been used for many years, and its use was discontinued because of concern about DDT on the environment. However, recently there has been a revival of the use of indoor residual spraying with DDT, and it is highly effective. Indoor residual spraying affects the vector, mosquitoes, to reduce the chance of being bitten by infected mosquitoes. Insecticide-treated bed nets are another tools that are being deployed in increasing numbers in mainly malaria endemic countries. Bed nets, usually insecticides, reduces the chance of being bitten by infected mosquitoes, relatively cheap and very effective. Malaria chemoprevention, either for prophylaxis for visitors to endemic countries or intermittent preventive treatment for residents of endemic countries. This involves giving anti-malaria drugs at regular intervals during time when one is at risk of developing the disease. The intermittent preventive treatment principle was initially applied to pregnancy and later on to infants and more recently in children. A tool that we are all been waiting for is an effective vaccine. Vaccines are quite cost-effective and will add to the tools currently available. However, there is no licensed vaccine available, and research is ongoing to try and develop an effective vaccine. I thank you for studying with World Med School.